Please be seated. The Crown against the University of Queensland Diamantina Institute.
Your Honour, my name is Derrington, initials SC, and I appear for the Crown in this matter. I'm informed that the defendant is so supremely confident that it has chosen not to appear this evening and is prepared to be tried in absentia. Your Honour, I present an indictment charging the Diamantina Institute that the money being allocated annually to medical research into chronic disease has been deliberately and willfully wasted by medical and scientific researchers within the Diamantina Institute, contrary to section 1365ZZT, subsection 1, subparagraph Q of the Thou Shalt Not Waste Act of 2005. The penalty for breach of the subsection is that members of the Institute who have participated in the offence will be required to serve for a period of 5 years on the University's Committee for Academic Programs Policy, CAP, with no reduction of time for good behaviour. Your Honour, ladies and gentlemen of the jury, chronic disease is defined in the Act to mean the NHMRC expenditure priority areas, being cancer, cardiovascular disease, arthritis, diabetes, asthma, and obesity. Waste is defined in the Act to mean the use of money contrary to the common sense of the reasonable taxpayer. To succeed in establishing the commission of this offence, the Crown must prove, first, that money has been allocated to medical research into chronic disease. Secondly, that medical and scientific researchers did not need to conduct any further research into chronic disease, and consequently, that the money allocated to medical and scientific researchers to continue to conduct research into chronic disease has been deliberately and willfully wasted. Members of the jury, you are all reasonable taxpayers, so you can bring to bear your own common sense to the task of deciding whether or not the Crown has proved its case. At the crux of this case is the allocation of a finite resource, your taxpayer dollar. The Crown proposes to call 3 witnesses, each of whom claims to be an eminent medical and scientific researcher. Members of the jury, after hearing their evidence, it is the Crown's submission that you will be inexorably and inevitably led to the conclusion that the charge has been proven beyond all reasonable doubt. I call the first witness, Professor Ian Frazer. Professor Fraser, will you take the oath on the Bible of genetics?
Your Honour, do I have to take the oath on the Bible? This is not my religion. Can I affirm?
You may affirm.
Should I stand?
You should.
I think I can remember how to do that. I affirm by Isis und Osiris that the evidence I shall give is based on legitimately funded research in accordance with the NHMRC guidelines and is not the result of doctored data sets or plagiarised findings.
Thank you. Please be seated. Would you state your name and address?
My name is Ian Fraser and my address is the care of the Translational Research Institute, 20 Cornwall Street, Wollongabba.
Thank you. Now, Professor Fraser, apart from being God's gift to women, do you have any other relevant qualifications?
I would profess that I am one of Australia's national living treasures, which is better than being a buried treasure. And that I have also been given the title of the little prick that may save your life.
Thank you. Professor Fraser, what is your particular area of research expertise?
My area of research expertise is the immunology of cancer.
And you've prepared a statement in this matter, And in that statement, you say that cancer is generally a consequence of age-related failure of the biological machine.
Generally, that is the correct.
And what does that mean?
It means that as we get older, we are more likely to develop cancer.
Through what causes?
A mixture of our genes and the environment, and basically the failure of our body to repair itself when there is genetic damage.
Well, why should we not let the biological machine fail? We have increases in the world population already beyond sustainable limits. What's the benefit in keeping these people going?
As one of these people who's getting older, I see a very positive benefit in keeping the increasingly aging population going. But I would also point out that there is a great advantage in having grandparents around to look after children when the parents are out at work.
Well, apart from the social benefits that you posit, is there an economic benefit to your research?
It certainly keeps me in employment.
What percentage of the gross domestic product is spent on healthcare at the moment?
In this country, approximately 8% at the moment.
And do you have a view on whether research into cancer and other chronic diseases might have a positive effect on a healthcare budget?
It certainly is better to spend the money effectively than to spend it ineffectively, and research enables us to spend the money more effectively.
Oh, that's a value judgment.
Indeed.
What do you say is effective spending of the research budget?
The use of drugs and interventions to prevent and treat disease in such a way that people live longer, healthier lives and are survivors. Cancer's a survivable disease. More than 50% of people who develop cancer now will be cured of it, and that compares with about 15% when I was a medical student.
And so would it be fair to suggest that you think that continued research would reduce the burden on the healthcare system in the long term?
That's the aim of research, certainly.
Has history shown that to be true?
Well, it's true that we spend more money on healthcare now than we used to do, and that figure is increasing steadily in every country in the world.
So despite the fact that you and your colleagues have managed to eradicate many diseases, nonetheless we continue to require ever-increasing amounts of healthcare.
The problem that we face is that we're inevitably destined, if we cure diseases when we're young, to grow older, and the more old we grow, the more expensive we become.
So in fact, all you are doing is prolonging life, enabling the further failure of the biological machine, and in fact increasing the ultimate burden on the health system and the health budget, because people will live longer, develop new and interesting chronic diseases, and require ever-increasing healthcare.
I'm supposed to be rendered speechless. I would point out that there is an alternative, which I would posit to you, and that is that we simply shoot everybody when they reach the age of 65. For the cost of $1, we could save a very large amount of healthcare expenditure, but I'm sure that the members of the jury would find that unacceptable.
Well, perhaps. Might depend on which 65-year-old we were talking about. Professor Fraser, what do you say are the major causes of cancer?
Well, cancer is a mixture of the genes that we're born with and the environment that we live in.
And what are the major environmental or lifestyle risks that contribute to cancer?
Well, we all know about the most of them. Smoking is the major one. Alcohol consumption, exposure to sunlight, virus infections, environmental pollutants all contribute to the burden, and together amount for about 30% of the cancer burden.
So you already know the causes?
We know these causes. I don't think they are everything, but we certainly know them.
So why do we need further research if you know that stopping people from smoking, drinking, promiscuous sex would solve most of those difficulties?
It would reduce the burden, but the point that we're really faced with is that it wouldn't get rid of it, and we really need to do something to make sure that we prevent the other cancers where we don't know the cause or where we don't know the contributing factors. I think it would also be fair to say that we're not very good at getting rid of the burdens in the environment, particularly the ones that we impose on ourselves. It's easy to say that we should get rid of them, quite another matter to actually get rid of them.
So you don't think there are ways to force people to make sensible healthcare choices?
It's been tried. It doesn't work very well.
Could we not simply refuse to treat someone who, for example, has been overweight for 20 years, smoked a packet of cigarettes a week or a day for 25 years, and then presents with cardiovascular disease?
We could, but I don't think that that would be what the community would wish.
You don't think a reasonable taxpayer might think that their taxpayer dollar is being wasted on someone who has made these irresponsible choices?
Well, let's look at the people who have made irresponsible choices and what they've contributed to the community. Winston Churchill was an avid smoker all his life. Dylan Thomas drank alcohol from an early age. Eric Clapton, to be more up to date, was also pretty good at the drugs and alcohol. Alexander the Great was a notorious alcoholic, and Mussorgsky was also an alcoholic. They all contributed very usefully to society, and I think the place would have been much the poorer if they had not been there.
So you think we should encourage alcoholism? Smoking?
All things in moderation. The community needs a certain number of alcoholics.
So what does your research really need to be directed at, do you say, to eliminate these lifestyle factors from the disease burden?
We need to be able to tell people that are at particular risk of disease that they are, so that they are encouraged to change behaviour by knowing that they are a little different from other people and at higher risk.
So what you're really saying is that the research funding that is currently made available to the Diamantina Institute would be better spent in the Faculty of Social and Behavioural Sciences.
If we felt that it could be usefully spent there, then yes, I might agree with that. Sorry for those who are social and behavioural science. The challenge we have is we know how to prevent these diseases through behavioural change, but we don't know how to change people's behaviour. I'm not sure that there's any evidence that research will help us do that. We know that the only thing that really works is financial penalties, and that's fine, because if we put financial penalties on these people, that will pay for the research that we would like to be doing.
Right. Thank you, Professor Fraser. You may be excused. I call Professor Matthew... No? As Professor Thomas wishes to go next, I call Professor Ranjey Thomas. Would you stand while you take the oath?
You want me to swear on a genetic Bible?
Please.
Well, I could quote you a chapter of the Bible. I believe man could quote you a chapter of this Bible. Okay, I'll swear by Emery and Remoy, medical genetics, that the evidence I shall give is based on legitimately funded research by the NHMRC in accordance with their guidelines, and is not the result of doctored data sets nor plagiarised findings.
Thank you. Would you state your name and address?
My name is Ranjey Thomas, and I'm at the Diamantina Institute, Princess Alexandra Hospital, Ipswich Road, Brisbane.
Thank you. And could you tell the jury your qualifications?
Well, when I was younger, I was named a young tall poppy, of which I was young then, and I've never been tall. I guess I was a tall poppy. And I've also been named a WIT, but that's Women in Technology Biotech Researcher.
Both those qualifications seem highly implausible, and I trust the rest of your evidence will be slightly more credible.
I apologise.
Professor Thomas, what's your area of research expertise?
My expertise is in the pathogenesis and designing new immune treatments for autoimmune diseases like rheumatoid arthritis.
And how much money was allocated to your particular area of research in the past 12 months?
About $1.5 million in the last 12 months, of which 1/3 of that is from the NHMRC, in which case I was able to leverage 3 times as much from other sources, commercial and philanthropic and non-government international funds.
And what can you tell us about the cause of rheumatoid arthritis as you currently understand it?
Well, it's a disease of ageing and of the immune system, in which the genetic basis, so about 70% of the disease is caused by genetics underlying it, and then there are environmental triggers. Now, unfortunately, they involve lifestyle choices. Smoking is bad news. Alcohol is good news. And pregnancy is good news, but unfortunately it's difficult to keep people in that state, so that turns out to be bad news. Breastfeeding, on the other hand, is good news, but it's difficult to maintain that into adulthood, of the child, that is.
And how long have you known about the cause and the environmental or lifestyle effects on rheumatoid?
That is where research has really helped. And if you look back over the last 15 years of research into rheumatoid arthritis, it was 15 years ago that the first study was published in twins, showing that there was a relationship between smoking and rheumatoid arthritis susceptibility. And it wasn't until further studies were done in the UK and in Europe, where a European team first made the connection between the genetics of the disease and the antibodies that develop in the disease and smoking. So that was all due to medical, not Australian, but funded medical research that made those discoveries. And then it's been in the last 10 years that we in our group have been putting together those findings and designing immune therapies based on the underlying genetics, the trigger of smoking, what it does to the immune system, and how to do something about it. So yes, I believe research has actually advanced the cause.
Well, that wasn't the question.
What was the question again?
The question was, how long have you known about these causes? And it seems your answer was 15 years. So in the last 5 years, you've continued to spend research funding on something about which you already know the answer.
Yes, but as I just explained in my long answer, the long form of the answer, which was longer than 15 years, it's only through taking one advance to another advance that has allowed us, with the benefit of hindsight now, to look back 15 years and see the trajectory of research, which before 15 years we didn't even know smoking was associated. And after that, we discovered how smoking was associated and what to do about it.
And what are you hoping your research will lead to?
Well, that's the great thing about research, isn't it? It's a question of hope. We hope for what we can't see. And what we can see, which is what's happened prior to us, it's easy with hindsight, we can see it, we don't hope for that. What we hope for is what we can't see. And that's what we dream about and what we imagine and why we do research, in order to hope for a cure or a prevention based on the understanding of research, which allows us to intervene in a disease and make quality of life better for patients.
But you must have a particular goal in mind that you're proposing to use this research funding for.
Yeah, so the goal is to prevent disease, to be able to intervene so that people know who is at risk through genetic testing, and to tell those people so that they can make a better choice about not smoking and about drinking alcohol and being pregnant and all of those things. Going to the dentist so that they don't get gum disease, which is another associated cause. And also for those people that already have the disease, to turn it off earlier than we would have been able to do with current treatments.
And how would you turn it off? With a vaccine?
So we've designed a vaccine in reverse, a bit like Ian's vaccine for papillomavirus, but in reverse. So instead of stimulating the immune system towards the virus, we turn off the immune system towards rheumatoid arthritis.
And what do you expect it will cost to achieve that outcome?
I expect if we're successful, it will cost another $50 million. But most of that will not be funded, if any, by the NHMRC. It has now attracted commercial funding, and if it's successful, that's the only way that it will actually be implemented is through international pharmaceutical input in order to bring this to the market.
And do you think it's reasonable for that sort of research to be funded when you could save the burden on the health system simply by telling these people or telling the world to stop smoking and for the females of the population to remain pregnant and pleasantly inebriated?
Firstly, reasonable is a value judgment. But having got that out of the way, we'll do both things. One is we will try to prevent people from smoking, and I think it's more likely that we can make an impact on those people who know they're likely to get the disease, rather than just the global, everybody should stop smoking. We've already tried that. The second thing that we will try to reasonably do is to... What was the question again? I'm a bit in trouble today.
Well, what I'm asking you is whether educating the public...
Yeah, okay, should we educate? Well, the other thing is that smoking is a hit and run in rheumatoid. So if you have ever smoked, you have an increased risk of disease because it changes your proteins and it will change your immune system forever. So that if you've ever smoked, without inhaling or with inhaling, who knows, it means that it's the unlucky few that have done that who have a genetic predisposition are at risk of the disease. Now, how expansive is our forgiveness? Do we say, well, you smoked once and you're at risk of the disease, or you've got rheumatoid, that's your problem, and we're not going to treat you. It's too late for you, even though you made the reasonable choice to stop smoking. I think that if you could, rheumatoid arthritis is now becoming a burden on society because the main people affected are those who are of the lowest education, who are most likely to smoke, who are most likely to be obese, it's another risk factor, and and we know that those with the least education are the most at risk of doing badly. So if you look at it that way, if we can make an impact on those people, as opposed to all the people that live good and healthy lives and never get any of these diseases, we're most likely to make an impact on the burden to the taxpayer by saving those people from getting a chronic disease. So I think that's probably the best argument, the economic argument, that we should do something rather than just tell people it's all your fault and we can't do anything for you.
So we're back to a reallocation of funding from health sciences to SBS as the solution. Thank you, Professor Thomas. You may be excused. I call Professor Matthew Brown. Would you take the oath, please?
I certainly would. This is definitely my Bible. I swear by Emery and Remoyne's textbook of medical genetics that the evidence I shall give is based on legitimate funded research in accordance with the NHMRC guidelines and is not the result of doctored data sets nor plagiarised findings. But it might be the result of genotyping error.
We'll take that risk. Would you state your name and address?
Yes, certainly. Matthew Brown, and I occupy level 4R wing of the Diamantina Institute.
And do you have any relevant qualifications in this proceeding?
Yes, I wrote a chapter of the Bible. It's the book of Matthew.
And your area of research expertise is?
Genetics, particularly genetics of bone and joint diseases, but genetics broadly.
And how much research funding has been allocated to the research of genetics, let's say just in the past decade?
Well, so I'm glad you asked us this question. We looked at the cost of the whole global genetics program since 2007, which I think is when you can accurately date the beginning of really modern genetics, and it cost roughly $250 million. And I've just got a few points to make here about how much that is relative to some other expenditures that I'd really value some audience feedback on. So, for example, it turns out that the Australian government is going to buy 100 Joint Strike Fighters. The first 2 of those will cost $130 million each. So it will cost more to buy 2 strike fighters versus the entire cost of the genetics program worldwide for the last 5 years, which has identified over 2,000 genetic loci. So can I just have a vote? Those people who would prefer the Joint Strike Fighter?
Professor Brown, it's inappropriate for you to address the jury directly.
There are some other comparisons I'd like to make as well. So the Australian government is purchasing 12 submarines of apparent cost $35 billion over the next decade. So that's a rough cost of $3 billion per submarine, when at the moment we have 6 submarines but don't have enough crew members to put more than one of them at sea at a time. So if I could ask the jury to vote quickly on whether they prefer submarines or perhaps the entire cost of the NHMRC for 3 years. Submarines? Silence. And then turning my attention to the legal profession, if I may. So,
we'll confine his answers to the questions, please.
Nonetheless, I think this is relevant to the question because it is a potential source of funding for all of that valuable research that we've heard about previously. So, in the United Kingdom, people have looked at when looking at personal injury claims, for every £1 that is spent or paid out on a personal injury claim, 85 pence is spent on the legal costs of it, compared with if you have a no-fault system, only 10 pence is paid out per £1. Now, the federal government in Australia is about to spend $6.5 billion per annum on a national disability insurance program. And so if we simply got rid of all of the lawyers for the system, we'd be able to pay for the entire NHMRC budget and some submarines.
Thank you.
It has been suggested to me. It has been suggested to me that you could even man the submarines with some of the unemployed lawyers. However, I'm slightly concerned at the concept of putting a few hundred lawyers together alone on a submarine for a few months, that it might not be conducive to harmony.
No, there is a well-known saying about how you tell the difference between a catfish and a lawyer, but we might leave that for later. Now, Professor Brown, you say that $250 million has been spent on the genetics program, and I accept that that might seem a modest amount in comparison to the other helpful statistics you've brought along with you this evening. But what in fact has that $250 million produced in terms of therapeutic outcomes?
So I'd firstly state that question is a little unfair, given that it takes on average between a basic research discovery and a treatment actually ending up in a patient something like 15 to 20 years. And it's only since about 2007 that we've actually started identifying genes. Nonetheless, there have been already some significant contributions that have been made through genetics that have led to treatments. So at the moment, for example, in osteoporosis, a common problem in the general community, so 2/3 of adults will have a major fracture due to osteoporosis during their lifetime. So 6 out of the 8 treatments that are currently in trial for or in use in osteoporosis have actually been identified through genetics. I'd say another one would be some research that we did ourselves at Diamantina Institute looking at the genetics of multiple sclerosis, where we identified that a gene which leads people not to be able to metabolize vitamin D makes them more at risk of multiple sclerosis. And that's resulted in trials looking at using vitamin D treatment as a preventative to stop people getting multiple sclerosis. That looks very promising. So there are a couple of examples, but it's pretty early days, and I think that you'll need to see this played out over the next 10 to 20 years to be sure what it's going to do.
And in the statement that you prepared for the court, you suggested that one of the benefits of the genetic research was that it is at least now possible for antenatal diagnoses of certain conditions.
Yes, that's correct. It's now possible to take samples and either from sometimes even just a mother's peripheral blood and detect some genetic abnormalities like Down syndrome. But it's also possible to perform whole genome sequences to identify any genetic abnormality from samples from a placenta villus biopsy, for example.
And when you find a serious abnormality, what's the usual response?
Well, actually, usually what happens is the converse, in that people are being referred because they are thought at risk of having a serious abnormality. And in the absence of genetic testing, nearly always that results in a termination of pregnancy. The availability of... Sorry?
You're a Darwinist.
No, I am a Darwinist, but not a social Darwinist, and there's a difference. So the genetics actually in this circumstance often gives people reassurance that they are at less risk and therefore prevents termination of pregnancy in that circumstance. But I certainly wouldn't be in favour of any system that led to, taking a purely scientific perspective, a narrowing of the human gene pool, because Darwin himself believed that you needed to have a broad gene pool for races and species to be successful, and social Darwinism is about narrowing the gene pool. It would be contrary to his beliefs and mine.
Now, if you are able to sequence the whole human genome, what do you see happening from that?
So I think that for most common diseases, we'll be able to give reasonably good predictions about whether somebody in their lifetime will develop those diseases. We'll also be able to tell them a lot about what treatments they'll respond to and what treatments will be safe in their cases as well. So I think it'll have very broad impact across medical practice. And I think
how do you envisage testing for this or identifying someone's genetic markers?
So I'm thinking that the cost of sequencing a whole genome will drop over the next 3 to 4 years to the level of an MRI scan, which most people think is a pretty reasonable cost. So I think actually it'll become quite widespread for people to have their genome sequenced.
And when will it be done? When will it be done?
Well, ultimately I think it would be nice to see it done at birth as part of the normal screening that gets done currently. So currently all children at birth have a heel prick test that's done to test for certain diseases, generally genetic ones, but things like cystic fibrosis and phenylketonuria and things like that. And using a sequencing approach, we should be able to detect all of those diseases and a whole lot more, as well as be able to have a major change to the practice of medicine enabled by that, where we'll be able to change practice to preventing disease as opposed to therapeutic approach of treating people once they've actually developed the disease.
And how are you going to do all of that testing without the consent of the child?
Well, so generally we get the parental consent, and parental consent for children's good health is accepted already in society and in medical practice, and I don't think this is any different.
This is more than consent for good health. This is consent to recording some very significant discriminatory markers for a person going forward.
Right, so here we're getting to the need for us to have a genetic non-discrimination bill within Australia. So the United States in 2008 passed legislation through the Senate and House of Reps there with only one dissenting vote, which made it illegal to discriminate on the basis of genetics in insurance or employment. And whereas in Australia, actually, we sadly had a bill introduced by one of the Australian Democrats, Natasha Stott-Despoja, in 1998, and it spent 8 years going through various committees before never proceeding. And we really need to have a genetic non-discrimination bill like that.
Professor Brown, I'd take you back to the 2,000 genetic loci that you say have been identified in the past 5 years. And in your statement, you said that they're all associated with common human conditions such as hypertension, obesity, arthritis, diabetes, and cancer. Now, we've heard from the previous two witnesses that if we can reduce food and alcohol consumption in some cases, if we can stop smoking and if we can increase exercise, most of these conditions would dramatically reduce. Is the cost of your research worth it?
Well, so I think the fact is that we won't actually be able to bring about those lifestyle interventions unless they're done in a fairly targeted way. That it's very difficult for us to get whole communities to change, whereas if you target change advice and programs to people who are at high risk of getting disease, I think you've got a much better chance of doing it. It's also not just about prevention. We learn also a lot about new treatments from genetics as well. So it's not a one or the other sort of equation.
Finally, can I explore with you what research funding you say you need? What does it cost to run the Diamantina Institute?
It costs us about $25 million a year for the research programs of the Diamantina Institute.
And the future plans that you have, what sort of funding do you need into the future?
So Diamantina Institute's about to move into a big new institute and grow in size so that we can do more research in things like arthritis, diabetes, skin cancer, blood cancers and things like that. And we're looking to build up the institute from around about 150 scientists now to about 250 scientists in the next 3 to 4 years. To do that, it's going to require increasing our income by a few $1 million a year. And that is going to come from a range of sources, but one will be from the support of generous people as well.
And from the taxpayer.
Hopefully.
I have no further questions.
Thank you.
So, Your Honour, ladies and gentlemen of the jury, may I remind you that your task is to consider whether research funding, that is your taxpayer dollar, has been willfully and deliberately wasted by the researchers of the Diamantina Institute. Now, I suggest to you that the evidence is incontrovertible. You've heard that the causes of chronic disease are largely already known and have been known for years. Smoking, drinking, overeating, but still, money continues to be spent to assist those people who are not taking any responsibility for their own lifestyle choices. You've also heard that the direct benefit of most research cannot be identified. You've also heard that medical research is in fact adding to the burden for the health system by encouraging and promoting the growth and longevity of an already unsustainable global population. What has in fact been demonstrated is that our researchers want their money for nothing and their chicks for free. Ladies and gentlemen, I suggest that you have no alternative but to return a guilty verdict.
Ladies and gentlemen, we now have an opportunity for you to ask questions of the three witnesses. Clerks of the court will be circulating with roving microphones, and I would ask you to raise your hands decorously and quietly if you wish to ask a question, and to name the witness that you wish to direct your question to.
I am the chairperson of the Ethnic Communities Council of Queensland, and we have a program on chronic disease. And I'm very interested with the genetics because some ethnic communities are, have a tendency to have diabetes, like the Polynesian. So I'm very interested in listening to your thing. So genetics has really play an important part in these things.
Gout. It's widely thought that's because they lived in areas where starvation was the normal environment, and therefore the populations were selected for genes that helped them survive starvation. And now that we're in a time of plenty, that has the opposite effect. So, yeah, very relevant to why different groups get different diseases.
I just wanted to ask this broadly, and didn't have a particular person in mind to ask, but I was wondering what the evidence was that behavioural interventions that are aimed at a targeted group would be more effective than general behavioural interventions. I mean, like, we know that, for example, young people are at more risk of driving accidents, yet that doesn't seem to stop them from driving fast or what have you. If there's other underlying factors, just if there could be a comment on that, please.
I don't know, is this working? Yeah. There's quite a bit of evidence that direct personal contact with somebody who has had a particular health problem or a particular consequence of behaviour will alter their behaviour in a number of different areas. Smoking is more likely to be given up by a relative of somebody who's had lung cancer than by the general population if somebody started smoking. Wearing a crash helmet is more likely when you're on a motorbike if you know someone personally who's had a bad accident on a motorbike. And there's quite a lot of behavioural science evidence to support that. How far out that extends into the community beyond the individual depends on how drastic the actual event is. And things which get headline news in the newspapers tend to have an effect across a much larger population.
So that's a bit of a carrot, and there's also sticks, of course. And if you're fined for not wearing a helmet, then you're more likely to comply. And the cardiologists are very successful in getting patients to lose weight, to go on exercise programs, and to stop smoking, because they basically say you won't be able to have your bypass unless you do it. So that's a stick. And unfortunately in rheumatology we tend not to be very good at that, because we don't really have something that we can withhold, because we pretty much have to treat people. So we're much less successful in getting people to stop smoking. But if we could prevent a disease because people have seen in their family what it does to them, I think it would very likely have the same impact.
Has it been passed to be, trialled on humans, so to speak?
It was a bit of fun what we had tonight, but I actually don't think anybody asks for any disease. I don't think it's right to say that it's their fault, no matter what anybody does. That we take an oath to treat people no matter what. We don't withhold treatment because of the way they were born or the lifestyle. So that's the serious part. Yeah. In terms of vaccination, it is a hope, and it is something that is being researched, and that we are spending taxpayers' money to do this research in the hope that we will be able to use it. But it's still quite early stages. There has been a preliminary trial in patients, and we're hoping that we'll be able to move forward from that to get something onto the track to market. But as you know, things can fall off the rails at any point on that track. But that doesn't mean that there will never be a vaccine. It means that the more we learn, the better we can refine the treatment so that we can eventually get there.
If we went back 30 years and looked at cervical cancer, we would say that was a chronic disease that we didn't know the cause of, and we would wonder about how we might prevent it. Nowadays we have a vaccine that we can give to people, maybe not at birth, but certainly while they are children, which effectively prevents the risk of cervical cancer. But the reason that's possible is because we now know what caused it. It was caused by an infection, and we have a vaccine for that. So that I think that the concept of understanding why chronic diseases come about does lead to early intervention that can help prevent the disease. And it's worth pointing out that it's really, we're immunising the community to prevent disease in the 2% of people who are, for some reason, at particular risk of developing cervical cancer, given that they get the infection. Most people who get the infection don't actually have a risk of developing cervical cancer. We don't really know why that is, but we do know that there are about 2% of people who are at particular risk. So we've developed a vaccine to basically protect the 2%, but we give it to everybody because we don't know who the 2% are.
And is there a high percentage of people that are undiagnosed, like with the undiagnosed in the autoimmune disease? What could you recommend for those people?
I think if people are worried that they should, especially if they have a family history, because we know that they're very strongly heritable, these diseases, and if they have a family history and they're worried about symptoms, to go and see a doctor, because sometimes, a 15-minute consultation can help you sleep at night by realising that there's nothing wrong, or that you can come back in 2 years and we'll check again. And it's pointless just being anxious. Just go and see someone.
Thank you very much. I've just got a question specifically about the HPV vaccine, and we're talking a little bit about sort of marketing and behavioural stuff in the public, and I've always been interested as to why it's marketed as a cervical cancer vaccine and not a HPV vaccine, given that the vast majority of the people who receive it will be protected against HPV and not cervical cancer, and surely that protecting patients against HPV has, excellent public health implications in reducing that kind of burden of disease as well.
The good news is that the vast majority of people who get HPV infection never know they have it. It causes them no disease, and it doesn't increase their risk of developing any disease that we're aware of. It's just those 2% that get the cervical cancer. The vaccine happens also to include protection against genital warts. It's still marketed as a cervical cancer vaccine. That's seen to be socially more acceptable. And yes, there is a marketing element in anything that you do in medicine. You have to persuade people that it's the right thing to do. But in fact, if you look at the benefit for the community in terms of immediate returns, the cervical cancer vaccine's biggest immediate return is that genital warts amongst women under the age of 25 have virtually disappeared as a disease in this country now. I know this because we've been trying to do trials in patients with genital warts, and we can't recruit women anymore to these studies. So it's worked, and that's the benefit. But it is a vaccine primarily to prevent cervical cancer, because that is a life-threatening disease, and one that we would really like to prevent on a global basis. And globally, cervical cancer kills 250,000 women every year.
And my teenage daughter thanks you, even though she doesn't know it. She's very grateful to have received that tiny prick.
Coming back to the conversation that we were having before, given that the demand for healthcare is basically infinite and the waiting lists are continuing to grow every year, at what point does personal responsibility, if at all, come into it?
Well, unless we ran a pretty fascist society, you have to allow people their own personal choices, and within what are reasonable guidelines about what's high-risk behaviour and what's not. And that's a societal decision to make, not something for the medical profession to make particularly.
We actually penalise people pretty heavily for what we regard as socially unacceptable behaviour. You just need to look at the increasing tax on tobacco, the increasing tax on alcohol, to realise that there are means of changing people's behaviour, or at least if you don't change it, they pay for it.
And then there's seatbelts and helmets, and we talked about that. And then there's the most recent, hiding the cigarettes. I think that it all comes down to where you draw the line, and that's where the debate is. And I think the line's getting further and further away from being allowed to do it. But we haven't, and you don't want to go to the extent of prohibition, because it doesn't work either.
Yeah, my name's Nick Groves. I'm a health economist. In Australia, we spend more and more money every year on healthcare, and our proportion of GDP is increasing. It'll be 10% within 3 or 4 years. And we see in the US healthcare bankrupting individuals and large corporations, and in this country bankrupting some state governments. And a large reason for the increasing cost is that we're inventing new treatments and new cures. So when do we stop increasing the healthcare spending by inventing new treatments and cures? And when do we think about allocating our existing treatments and cures as efficiently as possible?
I would like to take issue with that, because it's something that everyone trots out, that it's because of medical research and new treatments and cures that we're getting such an increase in cost in healthcare spending. From where we sit in the hospital, there's incredible waste in clinical practice. There's incredible waste in over-ordering of tests, in use of therapies, standardised practice, in non-evidence-based practice. And I would take issue that the sole cost of this increase in the GDP is because of new breakthroughs.
It's worth remembering that we actually spend as much on totally unproven medications that you buy over the counter in chemists as we do on the drugs that we know from clinical trials are of benefit. That's a community decision, but it's, again, an evidence of waste and resources. And I think that the correct approach to the business of increasing healthcare costs is to make sure that the dollars we spend are spent effectively. Yes, I mean, that means more research. It's called health services research. It's a sort of translational research, but it needs to be done. And we also need to accept that while people would like to think they can buy good health simply by not changing their lifestyle, but going down to the chemist and buying some vitamin pills, we've got to educate them to the fact that that actually isn't the case, and that they really do have to take some responsibility for their health. As Ranjey says, what was said this evening was said in fun to some extent, but we do have to emphasize that at the end of the day, we are at some level responsible for our own health. The education program has to start early. It works if you do it early. Kids that go to school and are told when they're primary school kids that they need to stay out of the sun learn the lesson. Some of them forget it when they're teenagers because we still talk about healthy tans and making that makes you look sexy. But it's a matter of culture. In the Victorian era, we were all very happy to have nice pale skin because that was the sexy look.
I also just say against my own interests that part of the problem is driven by the legal system. The overservicing that Dr Thomas is talking about is because Australian society is becoming so rigid that doctors feel compelled to overservice in case they miss something that's going to lead them to be sued.
Well, and against my own profession, I think the fee-for-service system has a role in it too. But anyway, but I wanted to highlight that there are actually quite a few interventions which have been major cost-saving things, that it's not universal that research leads to more expense. Some that were mentioned from my panel members to the left include, for example, the introduction of folate supplementation to prevent neural tube disorders, the introduction of vaccines to prevent polio and so on. I would include the introduction of neuroleptic agents for psychiatric disorders, which meant that the need to lock people up in psychiatric hospitals for the rest of their lives disappeared. In autoimmune diseases now we have treatments which certainly cost, but they actually lead people to be able to go back to work and prevent them from having early retirement. And those sorts of indirect healthcare costs are generally not factored in health economics analysis, and yet they are actually real societal costs. They just don't go within a particular election cycle.
Professor Brown, he referred in his responses to the interrogation to the fact that he was not a social Darwinist but a Darwinist, and I think this raises some quite important extra issues. The point here is that by providing better methods of treating people with genetically dependent infirmities, we are in fact conspiring to increase the frequency of the genetic lesion in the community. In other words, that the genes that lay at the base of some of these conditions will become more frequent because the people who have those conditions will survive, whereas previously they may not have survived, or at least not have reproduced. The question really is, what are the prospects of being able to treat genetic flaws at the source, that is to say, at the genome?
So I'm not an expert on gene therapy, but I think there are very few examples at this point of gene therapy that actually works and is safe in humans. And I think it's unlikely that in the near future that we will see gene therapy that makes a difference to the germline sequence of DNA in individuals, and perhaps ever. I think it's going to be an extremely challenging thing to do. But we should bear in mind that the total proportion of people with severe genetic single gene disorders is a small proportion of the general population. So these arguments that we're going to lead to a major accumulation of deleterious genetic variants in the community just don't hold with the mathematics of it.
we're also evolving at a much slower rate than the rate of medical research.
I think it's also worth pointing out that in 1909, when a very generous federal government first introduced pensions at age 65, average male life expectancy was 55. Today, it's 82. And I think the real challenge is certainly health costs are increasing as people get better at $60,000 a year for full-blown dialysis, and we do it now for people in their 80s where once upon a time we'd say sorry. So the challenge is, I think, for governments, because that won't happen, that you'll be saying to people no. The challenge is to say to people, you won't be retiring at 65 anymore, that we need to have a system that incentivises people to continue to work and allows them to continue to work to contribute towards the taxes that are needed to pay for the health and other systems that will support them.
Which will, of course, increase the cost of research, because we'll all stay at it until we're 80.
So rheumatoid arthritis, I know the figures for this, so that's how I can quote it, costs Australia $80 billion a year, and that's based on medical costs as well as loss of productivity costs. So any saving that we can make will impact on their productivity, which means that they can work for longer. So I guess that's kind of the argument I was making before, is that we really need to consider the economic bottom line of prevention and of better treatment of chronic disease, because then, you know, the sums end up better. We can't just say, we're not going to treat you, we're not going to dialyse you, good luck to you, because that doesn't help society at all, because we're less productive.
I was just wondering whether, paradoxically, we can summarise this evening by saying the best way to manage an ageing population is by educating the younger population.
The simple answer is we agree. Definitely that's the case, yeah.
Can you please advocate for us? That's perfect.
As a cancer survivor and a young one at that, I just want to say thank you for all the work that you and your colleagues are doing.
Well, that's very sweet of you, and I think actually the audience here are probably on our side. I suspect if we took a vote that most people recognise that actually the world is a lot happier place for people with illness now than it was 20, 40, 60 years ago. And that comes through the investment in health budget, not in submarines and strike fighters.
Unless you happen to be a strike fighter.
Or lawyers.
You mentioned earlier obesity as one of the risk factors for developing some of these chronic and complex conditions. How much evidence is there from the risk factors for obesity, things like inactivity and certain foods, to actually increase the risk of developing those certain diseases, or in types of cancer, increasing the risk of getting other types of cancers or remitting?
Well, obesity is certainly a risk factor for cancer. There's no doubt about that. 10% overweight, and you increase your risk of breast cancer, bowel cancer, several other cancers. The mechanisms are complex. Some of them relate to hormones, some to growth factors, some just to difficulty of early diagnosis of that particular cancer if you're overweight. So keeping your weight down is good. Is there a cancer-free diet? Well, that's a question that's often asked, and the short answer is really not. I mean, the one ingredient in diet that we know makes a significant difference to your risk of getting cancer is salted meat. If you eat more than 250 grams a week of that, you're likely to increase your risk of bowel cancer.
But otherwise, it's a case of a healthy, balanced diet. I think Fran Lebowitz put it as food forms a very important part of a balanced diet. And I think that's the right way to look at it.
Ladies and gentlemen, thank you very much for your questions. I now have the duty to summarise the case for and against, and then I'll invite you to cast your vote on the outcome of this case. Remember that this evening the defendant was unrepresented, and instead it was incumbent upon the Crown to prove her case. You might think that her eloquence, which was certainly outstanding, proved that there had been malicious and willful misspending of your money by the absent defendant. But you've also heard from 3 witnesses from the University of Queensland Diamantina Institute, who, while significantly less eloquent than the Crown, and certainly less well-dressed, were nonetheless persuasive in that perennially plausible positivist manner that scientists so regularly adopt. Witness 1, a little prick who lives at the Gabba, employed on public funds, gave detailed evidence of the cost of both ageing and the increased cost of ageing and the increased cost of medical research. It seems to me that he's an ageing researcher. He should know what he's talking about, and I think we will accord his evidence considerable weight in reaching our conclusion. Professor Fraser then led us in a slightly different direction and really argued that more money should be spent, I think, on behavioural science. And I felt that there were people in the audience who were attentive to that argument. Then we had the tall poppy. The tall poppy who avoids doctored data. Professor Thomas explained that only 1/3 of her research was actually legitimately funded, as she described it, by the National Health and Medical Research Council, and the rest of her funding comes from less well-informed sources. Her groundbreaking contribution to the future health of our society was, I think, a paper that she's either written or currently has in draft form on why women should maintain a perpetual state of pissed pregnancy while breastfeeding their adult offspring. There seemed little hope for the other 50% of the population, although no doubt another $150 million is needed to explore what we men might do, except I did note to always floss after meals to avoid gum disease. Professor Thomas went on to explain to us why she needs another $50 million for research into things she can't see yet. She did, however, offer great hope to obese, uneducated smokers. And for that, you must be grateful. Professor Brown, who wrote a chapter of the Bible, but whose main area of expertise seemed to be defence spending, and I was intrigued to learn also the prospective, productive redeployment of lawyers, argued for universal genetic screening at birth. Now, some complicated calculations will need to be made, and I was glad to know that we have a health economist on the jury who perhaps may be able to help us with this later, will be to determine the increased additional costs of medical research into all the offspring of those pissed pregnant women. Now, the Crown. The Crown relied principally on an argument about intent, that the defendants had I'm confused by Professor Brown in referring to defence, but the defendants engaged in willful and malicious misuse of taxpayers' money. She also, of course, made a very strong case for the elimination of the elderly and any member of this audience who engages in activities that might one day turn out to have been risky when we... The audience, on the other hand, the jury, I felt much greater confidence in your contribution this evening, and it has certainly helped me in my thinking about this particular case. You were much more nuanced, I felt, than either the Crown or our three witnesses. You argued for more strategic and targeted screening of communities, ethnic and otherwise, and of individuals, and you proposed, again, that more investment be undertaken into research into behavioural change. I felt that the jury understood very well the long-term nature of research, particularly of the kind of research that makes very large improvements to long-term health populations. Your questions also led each side of this case this evening to momentarily abandon their own case and attribute blames firstly to doctors and subsequently to lawyers. If you believe, ladies and gentlemen of the jury, in the long-term benefits to humankind of medical research, if you would like to see more money spent on your future health and see more lawyers employed in submarines, you will decide that the Crown has not proved its case. It's time, as one of you said, for the community to make its decision. Please indicate by a show of hands if you believe that the Crown has proven its case that money on medical research is entirely wasted by willful miscreants from the Gabba. Please raise your hand. Yes.
Oh, I had 2 proxies.
Are either of them lawyers?
No.
Then I'll accept the proxies. If you believe that the Crown has proven its case, please raise your hand. If you couldn't give a stuff, I think the case is narrowly lost by the Crown, and that this jury finds that more money should be spent on medical research and all lawyers should be redeployed into submarines. I would now like to thank Professor Derrington, Professor Brown, Professor Thomas, and what's his name? I'd also like to thank members of the audience for their patience and their considerable insight in question time. You all now get your reward. There are drinks and canapes on the terrace, and if for those of you for whom a future of perpetually drunk pregnancy is attractive, there'll be opportunities for that on the terrace. Thank you.